Good evening, everyone. Welcome to the weekly session about heart and lung transplant, which is being organized by Yashoda Hospitals and the Department of Heart Lung Transplant. Today, every week, we bring an interesting topic that is related to heart and lung transplant, which will be useful for the general public and for the physicians and the surgeons. Today is an interesting topic. Why? Because we deal with this problem in the day-to-day in our transplant OPD, whether it is in pre-transplant or in the post-transplant setting. That is a nutritional aspects in lung transplant, a difficult journey. It is really difficult because right from the physician, a transplant pulmonologist, surgeons have a lot of issues when the patients comes to our OPD, right from the pre-transplant timeline and to the timeline of after transplant. So there will be either problems of patient being having a low BMI or patient is having a overweight, and we take day-to-day help of our dietary department about how to optimize the nutritional aspects before transplant, which will really help the success of the transplant. So today our speaker is Shwetha Madam. She is our dietary Deputy Chief of Dietary Department of Yashoda Hospitals. Madam is usually involves in our day-to-day transplant query, especially with related to the dietary part. And she has helped in many ways, especially in the pre and post-transplant settings. And when she takes it daily around, we can understand that how the dietary part, once you optimize, how it will improve the success and how the patient tolerates, and which really improves outcome. So over to ma'am. Ma'am, today we'll be dealing about the dietary aspects in the pre and post transplant. And after this one, we'll have a small session, question and answer session, and then we'll wind up. Over to you, ma'am.
Thank you, sir. Yes, as you rightly said, sir, nutrition plays a very important role when dealing with the transplant patients, especially the lung transplant. Yes, it is. Is it difficult? Yes, we'll see how it goes about. So when I speak about pre and post lung transplant, as we know, is now the effective treatment for saving the lives of the patients in the end-stage lung diseases. But when we have variables in the pre-transplant session, and when we see the survival rate of the patients, nutrition status plays a very important role. As sir mentioned, the BMI, the weight plays an important role. Why? It's like a reserves for them. It plays an important role, the nutritional status of the person pre-transplant that goes further post-transplant, that carries forward. So that plays an important role in the post-operative complications, recovery, and also maintenance and in quality of life of the patient. So when I speak about any respiratory system diseases or nutritional status, it is two-edged sword, sir. Because of the respiratory diseases, the food nutritional status is affected, and because of the nutrition, respiratory system is also affected. Two ways. So there is increased energy expenditure, so the increased workload on your lungs, work of breathing is increased, the chronic infections and the treatment modalities that also affect the nutritional status, and the fluid restrictions or shortness of breaths, decreased oxygen saturations while eating, anorexia because of the chronic disease. So these are the things that we consider which impacts their nutritional status. And additional limitations we have is, yes, most of the nutrients absorption, metabolism is affected, abnormal production of sputum, vomiting, tachypnea, thoracic pain, they have anemia, depression, and altered taste secondary to the medications are also often present in these patients. So that affects their nutritional status, and they have difficulty in preparing meals due to fatigue and lack of financial resources, the support of the family, and altered metabolism. These affects the nutritional status. The other way, yes, end-stage lung disease patients frequently experience muscle weakness, deconditioning, and inactivity, which are all Reduced muscle mass and reduction in their quadricep strength is observed in the lung transplant candidates. So that will all result in the decreased quality of life over a period of years, even after transplantation, if they are undernourished before transplant. So yes, when I speak about the other side is effect of malnutrition. When they are undernourished, that affects the lung structure, elasticity, and also function. It even reduces the lung immune defense mechanisms and control of breathing, reduce protein and iron deficiencies, diminish the oxygen carrying capacity, low levels of calcium, magnesium, phosphorus, and potassium. It also compromises the respiratory muscle function at the cellular level. So hyperalbuminemia we commonly see in our patients as measured by serum albumin. It is an inflammatory marker. It contributes to the pulmonary edema and decreased osmotic pressure and allowing the fluid retentions in the patients. And the supporting connective tissues of the lungs is composed of collagen, which requires ascorbic acid, in a simple terms, or vitamin C. So adequate nutritional intake is important, but still there are certain, because of the respiratory diseases, the nutritional intake is changed. And when the nutritional intake is reduced or compromised, the effect is still on the recovery of the patient. So healthy nutrition before lung transplant, as rightly said, as sir mentioned it, the right weight, getting hydrated, the small portions, and controlling of the blood sugars if they are having any comorbid conditions. These are the things that we monitor when we have time for the transplant patient. When we come to our OPD, well, before the transplant, then we have the time to intervene the nutrition as required to get the right weight of the patient. Yes, sarcopenic lung transplant candidates or have the increased risk of post-early transplant outcomes. Lower muscle mass is determined as an increased risk. So body composition, not only the obesity or weight, underweight, normal, overweight, obese, we are now looking ahead of the weight. We are looking ahead into the body composition, preserving the lean muscle mass, which is the nutrition intervention is concentrated on preserving the lean muscle mass. We are concentrating on the body composition information as prognostic information rather than only the weight. So we all know there are Asian cutoff categories and blood sugars which have to be maintained. If the patient BMI is normal, he is an ideal candidate, and if it is overweight or obese or underweight, they are undernourished or overnourished, malnourished. So whenever a patient comes, we go it in a psychological way, right? Nutritional assessment is done where we see the physical assessment, their history, anthropometric, and also in support with the biological laboratory tests to evaluate the present nutritional status and estimate their requirements. Each individual is different, so we call it as nutritional care process. Nutritional assessment is done to identify the nutrition process. Why the nutritional diagnosis, we then come into conclusion of nutritional diagnosis, then intervention, then monitoring and evaluation. This goes in a cyclic way in a patient-centered care. Nutritional assessment, when I speak about their current diet, eating behaviors, current symptoms, which affects the oral intake, their weight history, previous weight loss or weight gain, food allergies, their use of oral nutritional supplements, and even nutritional focused physical examination is what we concentrate to understand their current nutritional status. So pre-transplant nutrient requirements, we give their nutritional requirements based on their weight, age, gender, metabolic stage, type of any organ failures associated, malabsorptions, goals, and comorbid conditions. These are all to be considered. Then I end up into the next stage of a nutritional care process, that is nutritional diagnosis. The problem, why the patient is undernourished, I identify the etiology, the root cause wherein the nutritional intervention is required, which is evidenced by these signs and symptoms. So we concentrate on the etiology, the root cause, to intervene the patients. Pre-transplant, the recommendations are different. It is almost like protein recommendation is 1.2 gram per kg, ideal body weight. Energy we change as per their weight and the nutritional status. Fluids as per requirement. Salt restriction would be based on if they have any fluid retention or uncontrolled hypertension. adequate calcium and potassium. The balanced ratio of the protein, fat, and carbohydrate is recommended to preserve the satisfactory respiratory quotient. So when I speak about all these, the nutritional care plan should be individualized. It is to each patient, it is different based on the patient, their readiness to change, resources available, severity, and other various factors. Nutrition care process is always associated with pulmonary rehabilitation based on the patient's additional support that are required when and where. Even the diabetes management as well as appropriate services depend on the patient needs and also ability or willingness to participate in it. So when I speak about lean body mass, that is the preserving the muscle mass of the patient. So the nutritional assessment has taken a step ahead to understand how much is the muscle mass maintenance of the patient, which actually improves the post-transplant outcomes. DEXA is one of to evaluate the sarcopenic efficiently, but when these are not available, we are looking forward for various other parameters. We'll just see it in forward. So one is creatine height index, is a measure of the protein nutrition and lean muscle mass. So if the main nutrition intervention is to preserve the lean muscle mass, the nutritional depletion is prevalent in the patients in the lung transplant. It is a risk factor for higher mortality. So preserving the lean muscle mass is the first step or the nutrition intervention for a dietitian to see on the patient for the patient working for the lung transplant. So why each patient is different? Yes, the nutritional needs of the lung transplant population are immensely varied, because the challenge we have is this. Individual nutritional prescriptions are necessary because transplants are provided to different categories of the lung disease. It can be obstructive, it can be suppurative, restrictive, or vascular, right from the patients underweight, undernourished cystic fibrosis who have the pancreatic insufficiency and malabsorption, where preserving or improving their weight is a very tough for a dietitian. To the other side of the story is older chronic obstructive pulmonary disease or pulmonary fibrosis, where they are at times obese. So each patient is different, and the nutritional prescription is individualized based on the patient's requirement. So this is what we do. Nutritional risk assessment, the low risk, moderate, and high risk, estimated energy and protein needs, and how much is their intake, the nutritional diagnosis, the prescription, nutrition intervention, monitoring, and daily monitoring in collaboration with the physician and the doctor. How does the treatment go on? We consult with the doctor and then plan our intervention and monitor and evaluate the patient. So nutritional intervention, improving the nutritional status pre-transplant. When I have time to improve the nutritional status pre-transplant for a patient, it actually improves the overall outcome of the patient post-transplant, overall ICU length of stay or overall cost. So I can monitor it, and based on their requirement and intake, we enrich the nutrition with the supplementation and also artificial nutrition like enteral and parenteral, where and when required for the patient, when we are not able to meet the requirement with one single source of nutritional medium. So this is the latest nutritional diagnostic tool for the malnutrition, where we concentrating on muscle mal assessment. There is technical approaches and clinical approaches, but when it comes to the clinical approaches, anthropometry, calf muscle and mid upper arm circumference, or the physical examination gives us a rough idea of their muscle mass, which can be done at the bedside, whereas the technical approaches like DEXA, impedance, or CT scans and all, these require expertise and also the availability of those equipment. So we are now looking after which is easily possible for the patients, where we can improve their muscle mass assessment by knowing their body composition in detail to know the diagnosis of the patient's malnutrition diagnosis. So this is a malnutrition care flow process, as we have already dealt with screening, assessment, diagnosis. So screening, assessment, when the dietitian does, then comes when I'm planning my care plan, intervention and monitoring. physician or the doctor involves with me in each step. When we counsel the patient, when I change my intervention plan, we monitor and observe the patient's outcome. It is I would say it is a responsibility of all of us three, physician, dietitian, and the nurse. It is responsible at each step. How do we go about? So nutrition intervention, it is purposely planned action that I change in their nutrition related behavior for the better growth and improvement of the patient's pulmonary function, and possibly more improve the quality of life and also survival. When we modify the nutrient energy or providing, we have to correct their deficiency, improve their oral intake. If they are not eating sufficiently, I have to increase the nutrient deficiency density, liquid dietary supplement, or when their oral intake is reduced, I take the support with the tube feeding or the supplemental parenteral nutrition or adapted model of the nutrition. I changed, modified the diet, fortified the diet, multiple servings, food textures, portion sizes, seasoning, flavoring, chopped, pureed. These are the different types of modified. We modify the diet based on their patient requirement and needs. These are the nutritional intervention in general or in specific that we do to our patients in the pre-transplant workup and after post-transplant too, as per the patient requirement. So it is always customized diet prescription. Whatever I deal with, the balanced diet, it should provide the calories and protein each day, and supplemental nutrition with my diet care plan. So, and I should ensure that they receive all the nutrients without any deficiencies going further. So portion control is important. The more effective strategy, both for the weight management, it can be undernourished or overnourished. The high energy dense foods, I give it to the patients who are, if you control the portion, the person having SOB or breathlessness, I control the portion and increase the energy dense in that food to make them satisfied and manage their body weight. And small and frequent meals, they keep on asking us, should we eat these many times? Yes, because of their respiratory disorders, they cannot eat a big meal at a time. So we distribute it over the period of days, small and frequent meals, and protein, high biological value protein in each meal, nutrient dense snacks, and early dinner. So the right protein is important from different sources. So we ensure that person requires, we know that the person requires adequate high biological value protein, but that should be from the right sources, right supplements. Additional to the protein, fat, or calories, the antioxidants and anti-inflammatory also helps in our patients with the essential lung nutrients, vitamin A, C, E, D. When we plan a diet, we ensure that the diet is comprised of not only the macro, all the micronutrients which are essential for the lung improvement. So I think of minerals, flavonoids, fibers, fatty acids, and vitamins to improve the lung homeostasis. So this is all as a clinical dietitian, when I'm assessing a patient, when I'm giving the nutrition intervention, we go with the support of the research. They are all mentioning that yes, there is an important role of nutrition management from pre-transplant evaluation, reaching the goal target BMI to prevent undernutrition whenever and wherever it is possible. Yes, GLIM criteria has come up to improve the body composition as a malnutrition clinical assessment tool. And if you can determine the nutritional problems of the patient at first of the admission, you can start predicting the problem from the beginning and start working on your solutions accordingly. So these are the latest articles that have been telling us, yes, nutrition plays an important predictor of knowing the malnutrition in a transplant patient, specifically lung transplant. It helps improve the patient's decrease the patient's mortality if we can maintain the patient's pre-albumin BMI. So timely nutritional assessment and intervention in any organ transplant patients will improve the outcomes of the surrounding transplantation. So we have all discussed about the malnutrition, impact of malnutrition on transplant. Yes, in the pre-transplant phase, nutritional goals include optimization of nutritional status and induced with post-transplant survival, degree of malnutrition, how am I preserving the lean body mass to reduce the loss of the lung function. But post-transplant, it's different phase again. The acute post-lung transplant phase, adequate nutrition is required to help prevent infection, promote wound healing, support metabolic needs, replenish lost stores, and perhaps mediate the immune response and meet the patient's macronutrients needs given their catabolic stage, high catabolic stage, any of the organ transplant. The requirement massively increased during the acute phase, almost like 2 grams per kg body weight. In the repletion, we plan it. We try to modulate our nutrition intervention plans. When we see the patient in day-to-day rounds, we discuss with the doctors, how can I increase my protein and calorie within the restricted volume? So to provide the maximum possible nutritional benefit to the patients. So immediate post-operative patients, they experience decline in the BMI and weight. It is a highly catabolic stage, and important role is we modulate the diet, maintain their weight, aiding to the blood sugars and preventing chronic metabolic diseases, and also reducing the complications like graft rejection. So nutritional guidelines post-lung transplant, yes, on any patient with a post-lung transplant, there are few transplant medications that they have to take for lifelong of the transplanted organ. So they need to change their diet to include less sodium, animal fat, because there can be risk of complications from high cholesterol, infections, diabetes, and obesity. So adequate calcium, vitamins are also required to help counteract the side effects. So balanced diet, as we all know, this is what is required for the patient. But this balanced diet, I ensure that the patient received it as per their requirements in different modulates of nutrition therapy. When they are taking orally, or when they are tube fed or through parenteral nutrition. Long-term adjustments after lung transplant should include taking immunosuppressants. They have to manage medications, therapy, lifelong care plan, living the healthy lifestyle, and more important is the emotional support is what is important. And immediately first month of following lung transplant, it is important to consume enough protein and total calories. You also needed added protein to help overcome muscle breakdown because of higher doses of the immunosuppressants that are given to the patients. On a long-term maintenance, weight control, hypertension because of the corticosteroids they are given in, fluid retention that we observe, we ensure the modifications in the diet with the dietary sodium restriction and weight management is also encouraged. Hyperglycemia, hyperlipidemia, these are the long-term side effects that we observe for the transplant patients. It is continuous monitoring throughout the patient to ensure that these side effects are minimized. Potassium restriction we generally don't do. We do it only as and when required. We advise the person, because they will be coming for the review, we'll advise the person only when they are high hyperkalemia, we reduce potassium, or else a normal regular diet is advised to them. And osteoporosis, this is a long-term side effect because of the excessive excretion of calcium inhibit the bone formation and suppresses the intestinal calcium absorption. So long-term calcium and vitamin D supplementation is required for the person underwent lung transplant. So healthy choices, we advise them what are the healthy choices. We try to cut down on their unhealthy choices by understanding their regular intake, by modifying their regular diet. So the only drug nutrient interaction post-transplant is grapefruit or grapefruit juice. It affects some medications which are given post-lung transplant, any transplant by the way. So it increases overdosage. So it is important to check the new ingredients which contains grapefruit juice or grapefruit. Just have to check that to avoid all the herbal products. So food safety, initially the solid organ transplant patients required immunosuppressive and antibacterial drugs that maintains the transplant organ function. But It can expose the patient to increased risk of foodborne illnesses from bacteria, viruses, fungi, and parasites. So it is always advised to be food safe. So safe food practices is important to clean, separate, cook, and chill, maintain correct time and temperature. So drinking water, this goes in a flow right from the pre-transplant to the post-transplant, during the transplant, and maintenance of the patient at the time of the discharge. So we continuously monitor them before the transplant, during the transplant, and after the transplant. And maintenance and regular follow-up is required to ensure that they're going on a right direction. So healthy diet on a long-term diet prescription for them would be in this way. So diet plays a vital role in maintaining the health in the context of organ dysfunction and transplantation. In the practical approach to support lifelong habits that will sustain organ function and also maintain optimum overall health. So to maintain good health, good nutrition, and healthy dose of exercise is required. Based on the patient requirement, dietitian modulates it in each step of the transplantation. Sir, any questions?
Is the slides over, ma'am?
Yes, sir. I'm done, sir. Yes, sir.
Okay. So thank you, ma'am, for the excellent talk, ma'am. I think we after your talk we can understand that how difficult or how difficult your decision is, and especially how it will help the patient in this different aspects of transplant. Uh, uh, Other members, if they have any questions, they can put in the chat box. Ma'am, I would like to ask you from our transplant department point of view, ma'am, what are the most common challenge that you come across or in your transplant related dietary issues, and what is your advice that you usually give to the patients in the pre-transplant? Because most of them will have underweight and like, for example, I think last transplant patient also, even after recurrent dietary supplements, they fail to gain weight and they become a little demotivated. So what is your usual advice to this group of patients, and what are the common challenges that you face, ma'am?
So the biggest challenge that we face is they are with lots of myths coming around, sir. So they come up with a baggage of myths, with especially with the lung health. So they, whenever we advise on certain diet modifications, they are not ready to accept it, with so many myths around. Because of this, that is going to severe the condition. You are telling me, ma'am, but we are going to suffer it. But when we try to advise them on that, it's not my opinion. There is we advise them, there is a scientific backup and all those. So, and making them understand that it is required for their health and you have to do it consistently. So the biggest problem for our when we even have to play a role of psychologist at times, because we have to tell them consistency is important. When they come and take the diet advisor, they think that's forever. So they don't turn up again. So when we communicate with them that, yes, are you following it? I'll just give you a single example, sir. If I advise of any supplement that they are supposed to take, the supplement prescription, what I advise is different, what they take would be different. So the scoop size, the scoop is very big, ma'am, so I cannot take it. So the scoop, they choose of their whole household scoop. So the quantity varies. So for them, monitoring it and advising them, so this is required for you, and you'll not see changes in the weight immediately because it's a chronic problem. So the first challenge is I should not ensure that they don't lose much muscle and weight further. The first challenge is that, sir. Then I can think of putting on weight. Then they can think of putting on weight. First challenge is they should not lose further muscle and weight. So counseling them and regular follow-up is the biggest challenge for us.
Okay. I think from all the previous patient, I think like what you said is very true, because we can understand the patient and the relative to convince about the diet is the biggest challenge before proceeding further.
But the advantage that we will have is when our physician supports us, that we have right now, actually. So when our physician says, ma'am, this is your role, whatever ma'am is like, they are in that field, they will take it forward. So the patient attenders will also get the confidence that, okay, they're doing it as a team, then it's easier for me to convince them.
Correct.
So that is actually happening. So now we are seeing it in a good form.
Okay, okay. That's a good way to...
yes, sir. When we do it as a team, for them it looks like we discuss with each other and do, and they will be very much satisfied and confident in whatever the nutritional support that we are giving them.
Okay, okay, okay. Ma'am, other most common queries that that everybody has, especially after transplant, is how soon we start the feeds, ma'am, especially after transplant when they were on ECMO or when they're extubation or in that acute setting. What is your advice to the physicians or the intensivists about when to start the feeds?
Sir, if they are not on multiple supports, then I think like if you are not initially, as per the guidelines, you can start off after 6 hours. But go slowly, trophic feeds. I'm not thinking of the targeting the goal calories. It's just a trophic feeds. It can be just for the gut motility. So you can start off slowly. But sort of slowly, at least 20-30 ml per hour, that would be good enough. So if we find any complications associated, then we can stop, or you can reduce it, but you can go slowly. And after 6 hours, it is advised to start off in any of the surgical cases and the organ transplants too.
Okay, ma'am. We from your daily rounds, we often hear the word peptamer. Can you just brief about how peptamer is nutritionally rich in the ways, especially in the post transplant period?
So peptamen is one of the supplement. It is like peptides based, MCT enriched. So MCT enriched, it is 70% MCT enriched. That means that easy to absorption. So it is easy for the person to absorb without much digestion and so initial phases of the transplant, we prefer that to ensure that it get absorbed faster and it doesn't have, I can say in simple words, it doesn't give much strain to your GI tract.
Okay, okay, okay. Sure.
So it's a MCT based, so easy to absorb, peptide based. So initially it is always better, and going further, I can go with a regular standard supplement of increased calories and proteins. Peptamen is one brand name, sir. Actual composition is pure MCT peptide based.
Okay, okay. I think Vikram sir is probably, I think he's joined as an attendee. Sir, can you hear me, sir? Okay, I think sir is not responding.
Sir did not unmute.
Sir, can you unmute, sir? Okay. Okay, probably when he's coming, then we'll ask his inputs also. And other thing is that, ma'am, we often feel that more early when we start the kitchen feeds and other thing, their motility improves and it actually improves their progress, especially while in the ICU when we are weaning many of the supports and other thing. What is your opinion regarding that, ma'am?
So kitchen feeds, we have stopped using it. The biggest challenge is the safety. Okay. About we are not thinking about the calories. We all know that kitchen feeds doesn't give up calories, only for the a little, as you say, for the motility and all, you can get without thinking about the calories, but the food safety is more important for us. So we have removed that from our protocol, that to give in any of the ICUs, we are starting off with only the supplemental nutrition, which is bedside preparation. Immediately after prepare, it can be provided to the patients. Okay. So there's a safe mode of providing nutrition.
Okay. Because I think that safety, I think, is of a big concern, especially post-transplant.
That's the reason. Yes, sure.
Because many of the patients, we advise them about not to have, especially the juices which is from roadside, which is not packed, and there are many things which actually it's little concerning when the patient get discharged and go home. And many of them have a doubt, especially regarding can they take milk that cause increased cough, and can they take about any different juices that we should avoid after transplant. Do you have any specific inputs regarding that, ma'am, about any specific juices that we should avoid?
So it can be pre or pro transplant. We encounter with in day in day out in every ward rounds of my in pulmonary ward about the milk, curd. We'll have a questions. So curd will definitely induce cough. So how can we give it? But when it is freshly set curd, it is actually good for the probiotic. So they will already be on antibiotics and all. So we try to explain them that that is very much important for them for the gut microbiota. So you start taking it, but don't take it directly from the freezer and have it and think that it is the cause for your cough. But their disease condition itself is because cough will be there. So they should understand that it's not increased because of that. That is not because of the, the curd that you're taking. So the milk also, that is the biggest myth that is being running over the ages, sir. So, and also banana. These three are actually, they were very much concerned when it comes to the lung health and cough. So we try to explain them, we convince them and modulate the changes and tell them the scientific background of why you should take and why not, in what form, the fresh forms you have to take. Few accept it, few take time, but reinforcing it in the same way again and again will actually works in some cases. And we have seen few differences in our previous transplant patients too.
Okay, that's a good sign about how patient is accepting after telling with the scientific evidence and other things. I think, ma'am, there are no further queries. Ma'am, what finally to wind up, ma'am, what is your advice to the patients, especially in the your advice, especially to patients in the pre-transplant, and what is your advice to patients, especially post-transplant patients when they are going home? Just in a one sentence, especially both settings, ma'am.
So I would say only one thing, sir. Nutrition is as important as your medication prescription. So do take it as seriously as you take your medication prescription, because you are supposed to take those medicines. You have to for lifelong or certain period of time. When you do it as a follow-it up, why don't you do it with a diet and nutrition? Because that is as a backup. Unless you have the nutrition, the medications will not get used by the body. They'll not understand that. That is more important, sir.
I think this session, I think would have been very valuable to many of our patients who will be listening either in a recorded version or in live session, especially about the different myths and what are the different facts from a scientific point of view and from a dietitian point of view, which is really important. I thank our Shwetha ma'am for participating in this webinar, and it really enriched many of the myths and many of our queries that we had, especially from a dietary point of view. We look forward for further sessions, ma'am, regarding the dietary inputs, especially in transplant. I think there are no further queries. So thank you, ma'am, for all the support.
Thank you, sir.
Thank you. Okay, good night.